changing from anatomical stage, clinical stage, surgical stage. Now the trend is towards molecular stage. And the prime example nowadays is endometrial carcinoma. And I think among gynecology, the most debated topic and whose chances to become is this one only. If it will be definitely asked in the exams, practical or theory. So in both perspective, this topic is very important, needs discussion, as it is not that easy to understand and it needs multiple revision and discussion, so that should be confident in daily practice as well as during examination. So during discussion, if anybody has questions, and even it is not fully clear to me, so even if I have any doubts, I will ask you. If you people have any doubts, you please let me know. So I will start with this EGC. As we know, the tumor genomic cancer atlas. This is that forum who actually makes all these genetic testing, this genetic workup of all malignancies. They came up while assessing these genetic mutations in endometrial cancer. They came up with 4 most common pathogenic mutations in an endometrial carcinoma. So while analyzing and framing the data, they came up with these mutations, as we all know, pole mutation, MMR deficient, P53, and no specific mutation. So in a flow chart, how to approach a patient of endometrial carcinoma. So whenever a patient of endometrial carcinoma comes to us and we are subjecting for a molecular testing, we first should do pole testing, pole mutation. If it is pathogenic, we call it directly pole mutant endometrial carcinoma and no further genetic testing required. If it is wild type, that means pole mutation is not there, we will go for MMR status. That is the second step. So if MMR is deficient, we call it endometrial carcinoma, mismatch repair deficient endometrial carcinomas. Even if both pole mutation is not there, MMR mutation is not there, we then called it MMR prolificent pole mutant non-wild variety endometrial carcinoma. Then we final subject it to P53 mutation. If it is a mutation is P53, we call it as endometrial carcinoma P53 mutant. Even if among all three, if all three are negative, we call it no specific mutation present endometrial carcinomas. But the problem with this algorithm is like this. But the problem is that pole mutation needs next generation sequencing. So in our subset, it is very expensive and not easy to do. So now the pathologist usually they go directly for P53 first. They come in a reverse manner. So if it is there, MMR is there, so directly that one is ruled out. But as per the guidelines are, we should first do pole mutation, then following the others. Is that clear till now? Hello?
Yes.
Okay. So how to differentiate between these two? So if we remember the previously, we used to classify endometrial carcinomas type 1, type 2. So it is just a filtration of that things in the view of genetic makeup. So if we see pole mutation, they are high grade endometrial CAs and tumor infiltrating lymphocytes are present. So as we know, whenever there are tumor infiltrating lymphocytes, the prognosis is indirectly good. So that's why we tell pole mutation patients, because of the infiltrating lymphocytes in vivo are there, that might be a reason they have a good prognosis. So if MMR deficient is there, they are also high grade. They have also tumor infiltrating lymphocytes, but LVSI in these subset of patient is present. That makes them a bit bad prognosis as compared to pole mutant. Then we have the worst prognosis, that is P53. So they are high grade lesions and TIL are totally absent. When TIL is absent, as we know, they directly prognosticate on pathological specimen. That makes it a worse prognosis among all. And this no specific mutation burden, TIL absent, but they have ERPR positive and they are low grade. Low grade makes them a good prognosis. So as I previously told you, diagnostic testing in pole mutant is NGS only, and rest we can do on IHC. So clinical features in pole mutation is that low BMI, early stage, excellent prognosis, young female. And MMR, as we know, MSI, they have the Lynch syndrome variety of patients, these MMR patients, and have higher BMI. These P53 mutations are advanced stage. Whatever is bad, it fits into it. Is P53. Bad prognosis, higher BMI, advanced stage, high grade, EILM, everything will dump into it. And NSMP is intermediate and BMI is high. Prognosis, as I told, excellent in pole mutant and worst in P53. The rest fall into in between. So prevalence is pole mutant is 12%, and highest is MMR, MSI. So if we see genetically, this pole mutant is ultra mutated, 100 megabase pair mutation burden is there, and microstellate stable tumors. And MSI, as we know, the second one is hypermutilated, not ultra mutilated. 100 mutations per megabase pairs, and MSI is present. Instability is there. P53, as we know, but they are MSS stable tumors. These no specific mutations, less tumor burden, making them good prognosis. Microstellate stable tumors, and P53 wild variant. So when many studies, especially in PORTEC3, they analyze the data, they saw the survival of pole mutation is very good as compared to P53. So when this mutation, this molecular profiling was done, they went back to the PORTEC3 data, which was chemotherapy, chemoradiotherapy plus radiotherapy outcomes in a high risk population. They went back to that pathology specimens and saw the survival of patients and compared the survival data with these pole mutations, and they saw pole mutant patients have very good survival as shown in the figure. So in the PORTEC3, they re-again back to the data and saw data of 410 patients. These patients were endometrium 3, 1B. I will just revise you the uterus previous FIGO classification. 1A was less than half a myometrium. 1B is greater than 50%. So stage second was cervical stroma, and stage one, these are the patient subset whose histopathological report they analyzed and correlated with the molecular profiling. So among 43 patients, 93 cases were P53 abnormal. As I told you, P53 is the worst among all. So they saw 5-year overall survival in these patients was only 43%. And these patients who received chemoradiotherapy has 59, means 60% survival as compared to who already received RT. So among 93 patients, 60% had a good outcome who have received chemo RT. Indirectly mean the patients of endometrial cancers with P53 mutations get benefited with chemoradiotherapy, not only radiotherapy, despite of what the stage is. Then among 410 patients, 51 cases had pole mutation, and 5-year survival excellent. 98% were alive at 5 years, and chemoradiotherapy 100% patients alive, RT is 97, and it was not significant. So indirectly it means that those who are having P53 patients, we are overkilling the patient, over treating the patient with chemotherapy, and when compared to RT only, because the difference is only 3% among these two groups. Among 410 patient POTEC patients, POTEC 3 trial patients, the 5-year survival was 72%. It is better than P53 mutation, but not as good as pole mutant. In between, these MMR and NSAB is having in between characteristic between P53 and pole mutant. So at one extreme we have P53 mutant endometrial cancer, at other extreme we have pole mutant. So if we see this POTEC 3 data, just this small page, we can just comprehend that we are over treating the P50 and this pole mutant patient, and POTEC 3 we have under treated the RT, this P53 mutation patient. So common sense wise, the treatment has to be de-escalated in pole mutant variety, and treatment has to be escalated in P53 mutant patients. And MMR and NSPP, depending upon the situation, case basis, you can take the call. Is that clear till now? Hello?
This is only for stage 1 disease, I think.
I will come to stage 1. I will come to stage 1. This is just their data, what they have. This is in above you have seen, they have taken grade 3 1B LVSI, both stage 2, stage 3, stage 1 to 3 disease, they have all taken together.
Okay.
They took all the data, all the specimens in POTEC 3 trial, what they have done, and they just analyzed the survival with pole mutation and P53 all mutations.
Okay.
It was not stage 1, stage 2. They gathered all the information, tabulated it, and then got separated in 4 different columns. Who have P53, who have MMR, who have pole, who have no mutation. Okay. Then second column was they saw the overall survival. Who survived better? And you can see P53 had a worse survival. They, irrespective of their stage, irrespective of their grade. Okay? Is that clear till now?
Okay.
Mohan, is that clear till now?
Yes.
Okay, don't confuse. I'm not going to stage till now. I will come to later on.
Okay,
fine. So from this data only we can get that P53 has a worse prognosis, and we are over treating because RT and chemotherapy, 60% patient had a good outcome with CTR, but bad outcome with RT only. You are getting this point?
Yes. Under treating that pilot type, P53 mutated type.
Yeah, we are under treating, and from this, just simple, if you go to this chart, we are over treating pole mutation and we are under treating P53. Okay, because you see 97% 5-year plus and 100% in CTRP. So 3% is nothing. Okay. But in P53 you see 36 and 60%. It is a huge difference. Okay. So if that RT patient would have received chemo RT, the difference would have been better. Okay. So then they risk categorize. A bit a dry topic, but just if you have in mind, you will read it again and again, it will come to. They then risk categorize the patient. High, intermediate, low, intermediate, high risk categories. Pole mutation, whatever it is, stage 1, because in risk category 3, 4 stages are already advanced. There is no confusion in those. The early stage 1 and stage 2, especially stage 1, needs risk classification, because in that stage we have to decide whether patient needs adjuvant treatment or not. So in that subset, early stages, they have reclassified. This earlier there was high risk, low risk, and intermediate. They reclassified depending upon the molecular classification. So pole mutation, whatever the stage is 1 and 2, whatever the grade is, they have put it in the low risk category. You understand? And P53, you see, only stage 1 is intermediate risk, rest all is high risk category. Okay? In between follows the MMR group and no specific mutation. Okay, so from this risk category, from the data of Cortex study, they have given us a concise treatment depending upon the molecular biology. How will you treat? Stage 1 tumor is there, so no further treatment is required. If it is stage 1, grade 1 to 3, whole mutant, whatever LBSI is there. If it is stage 1, low grade, MMR deficient, LVSI is slightly present, still you won't treat the patient. No adjuvant RT to be indicated. Brachytherapy is only given when it is stage 1, grade 3 endometrioid, MMR deficient, LVSI is not present or it is focal. If it is stage 1, P53 is abnormal, stage 1A only. Just see, stage 1A we didn't use to treat. If it is stage P53 is abnormal and it is non-endometrioid type. Non-endometrioid is serous, clear sir, versus other bad histopathologies. Brachytherapy is only given in the MMR patients if it is stage 1 or B, grade 1 to 3. EBRT is to be given, that means treatment has to be escalated in stage 1 when it is 1B, that is myometrial invasion is there, grade either low or high grade, if P53 found to be abnormal. So from this we conclude that if P53 is abnormal or it is non-endometrioid pathology and myometrium is involved, patient needs EBRT or chemotherapy. Clear? Then in stage 2, observation still, if it is pole mutated in all grades, RT if it is MSI high, chemo RT if it is P53. Clear? Stage 3 and 4 all it is CTR. What I tried to describe what is the mutation, how it changed the risk categories, what is the concept behind, how the data was extracted from the studies previous, how they formulated it. I am treating as per ESCO Astro consensus. Although it doesn't, I don't think, I have not checked NCCM whether this treatment came. I am giving what the treatment they proposed. So a bit more dry topic because they have changed the staging also. Pico 23 endometrial staging changed. Why it changed? It is all because of this molecular staging. So it was a bit easy previously. Now it is completely changed. Okay.
Do we need to remember this new staging? Very difficult to remember it.
It is very difficult. That's what I told. I don't know. But if it comes, what we have to write? We should write the previous one or write one?
This one only we have to write. This one only we have to write.
Because it is entitled in FIGO 23.
FIGO.
Yeah. Although lot of criticism is there, but I think this is till now this is the latest one on. Because
after that one ESMO guidelines
simple.
We have discussed in the middle. One ESMO guidelines we have discussed with this endometrium. They have given management according to the new guideline. That we can write for management.
When you discussed?
Before, when you were not there. I think only 2 or 3 people have joined that day. We'll send one link. One of our junior only discussed that topic.
Okay. Maybe
so this is the new.
उस दिन कोई नहीं सुना
लेकिन बहुत ये वाला this is very dry, this new one. So इसमें कुछ एक ही point, 1-2 points important है. बाकी तो ये याद ही रखना है. So previously it was just simple less than 50, more than 50 myometrium that has gone. So it is now stage 1 confined to uterus or ovary. Now ovary is also been included in that. 1A, 1B, 1C. 1A further divided. into non-aggressive histology, the 1A1, limited to endometrial polyp or confined to endometrium. 1A2 non-aggressive. Non-aggressive histology is anything except endometrioid, involving less than myometrium with no or focal LVSI. 1.3 is low-grade endometrial CA, limited to uterus and ovary. There should be no breach in ovary like that. So 1B is non-aggressive histology with invasion of half or more myometrium with no focal LVSI. Aggressive ones is aggressive histology limited to polyp or confined to endometrium. So changes in FIGO 2009 and 23. So the changes are defined now by combination of following features. There is histology there is myometrium in 1A, presence of extension into hour of n, LVSI has been added. Categorization of 1A, 1B defined by FIGO 2009 now only applies to non-aggressive histologies. Right. So introduction of ovary involvement as allowed if the following criteria are present: low-grade endometrioid type, absent or superficial myometrial invasion, less than 50, absent or focal LVSI, absence of additional metastasis, ovarian, unilateral or limited to ovary without capsule rupture. This is comparison to previous and later. Similarly, second stage also messed up. So second is invasion of cervical stroma of non-aggressive histology, substantial LVSI is present, aggressive histology with any myometrial involvement. This is invasion of cervical stroma. Stage second, what has changed? Defined now by combination of following features: cervical stroma involvement, LVSI included in this also, histology also included with myometrial invasion. Now been subdivided as I told you the previous. Stage 3 is invasion into uterine serosa, adnexia, both by direct or metastasis. 3A1 is separate to ovary, fallopian tube, except the criteria 1A3, which is the stage 1. Stage 2A2, involvement of subserosa, spread through uterine serosa. Likewise, stage 3 and stage 3, they include the micrometastasis, that micrometastasis and isolated tumor cells. So this is this. If you have time to read, I just want to emphasize only one point amongst all, which was my topic. It is stage 4, also got changed. See what has this point, this slide I want to discuss, which is relevant to my today's topic. See, if we get a patient of early endometrial cancer, stage 1 or stage 2, so that is in short terms, which is limited to uterus only, and you get a pole mutant, even if it is stage 2nd, and it is a pure mutant, you will still categorize it stage 1A, pole mutant. And if there is P53 abnormality or mutation found, and even if it is stage 1A, the stage gets upstaged to stage 2nd C, pole abnormality. So now the staging is being determined mostly by the mutations that a patient is harboring, especially early stages. Early stage cancers, even though if it's in second stage, 2B, harboring a pole mutation gave out downstage and treatment is de-escalated. And a patient with P53 mutation, even if it is very low disease, confined to endometrium only, not going to myometrium, and P53 is found, the treatment has to be escalated. Okay, it becomes 2nd C. Hope I have cleared a bit today my topic. Hello? Hello?
Yes.
Good. Yeah.
Yes.
Very well told.
Simplified, very simplified, but very confusing to remember.
हो गया.
Yeah, only this. this
देखना
अरे सिंपल सा
staging is
है,
very
अगर
complex.
एग्रेसिव कैंसर है, इवन 1 स्टेज का भी है पर एग्रेसिव कैंसर है तो पेल्विक लिम्फ नोड डिसेक्शन भी करना है और उसको वो भी करना है, आरटी भी देना है। पर पोल म्यूटेशन में स्टेज 3 में भी नहीं देना है, सिर्फ स्टेज 4
कुछ नहीं करना है ना, कुछ नहीं, नथिंग टू बी डन,
और
नथिंग टू बी डन।
नहीं पोल म्यूटेशन पर स्टेज 3 स्टेज 4 irrespective of molecular markers से आउट हो chemo radiation.
I was going through an article, they told
एस्मो
nothing to be done.
गाइडलाइंस को पढ़ना पड़ेगा, वो पढ़ा था लास्ट टाइम, बताएंगे भेजेंगे।
पर स्टेज 3 स्टेज 4 पोल म्यूटेटेड ऑब्जर्वेशन है क्या?
3 का मुझे श्योर नहीं है, 4 का मुझे श्योर है।
3-4 में बोलते, पोल म्यूटेशन में वो बोलते हैं द ओवरऑल सर्वाइवल विद और विदाउट ट्रीटमेंट इज सेम ओनली।
सो स्टेज 3 4 में भी पोल म्यूटेटेड है तो कुछ नहीं करना ऑब्जर्वेशन।
4 में नहीं, 4 में करना है, 3 में नहीं करना है, ऐसे मुझे पता याद है पुराना।
वो ट्रीटमेंट है, गाइडलाइंस है उसमें।
मुझे जहाँ तक पता है इट इज ओनली फॉर स्टेज 1 2
ना
because for stage 3 4 whether it is pole mutated or not mutated you have to
I think I have mentioned it also. Stage 3-4 will go for chemo radiation.
you have mentioned it.
Yeah, I have mentioned it. Stage 3-4 all need CTR.
That's right. With 4 lakh deaths occurring between 2000 and 2049. Age onset is elderly male patient because of long latency between exposure and disease occurrence. 50s, 60s or 70s. Latency of 25 to 40 years. This was observed by Lancer and Buncher after reviewing 21 studies. And mean latency of 32 years was seen. Male to female ratio is 4.5 to 1. And the pleural to peritoneal mesothelioma is 1:1 ratio. Mechanism of asbestos carcinogenesis. Asbestosis, there are 6 different types of mineral fibers. All together are called as asbestos, but the top 5 are together called as amphibole asbestos. Okay. But in human entity, these two, erionite and antigorolite, they share common structural and chemical characteristics.
Check once is anybody is waiting क्या to get in? Participants में आएगा।
I have to check that.
Please do admit
I have
करके
to check
आएगा।
that. I don't think so. कोई नहीं है।
Ishfaq I think trying to get in.
Admitted. हो गया ना 6 members.
हाँ, अभी तुम्हारा स्क्रीन गायब हो गया।
गायब हो गया, आ जाएगा 1 second. ठीक है? ओके. मैकेनिज्म है कि asbestos exposure, chronic inflammation, cell necrosis, and from the cell there is release of high mobility group OX1 into extracellular space. This HMGB1 is released by the mesothelial cells as well as macrophages. ये क्या करेगा? This HMG1 will stimulate these macrophages and mesothelial cells to stimulate and release human necrosis factor. This in turn activates nuclear factor kappa beta pathway. इससे क्या होगा? This makes the injured cells to survive with this chronic inflammation for longer duration of time. ये मरेगा नहीं. With this insult, these cells continue to survive for longer duration of time. इससे क्या होगा? As they keep surviving, at the same time they are continuously exposing themselves to asbestos, which are causing genetic changes within the damaged cells. These damaged but viable cells proliferate into mesothelioma in a later time. ठीक है? Asbestos carcinogens humans, but all people who are exposed to asbestos will not develop malignancy. There is some genetic susceptibility, especially in DNA repair mechanism, germline mutations has increased susceptibility to asbestos and to mesothelioma. As I said, erionite, crocodylite, and amosite, most potent mineral fibers to cause mesothelioma in humans. And why not chrysolite, which is commonly seen? Because for any mineral fiber to cause a malignancy, it has to be there in the pleural cell for longer duration of time. A chrysolite को क्या होगा? It has limited biopersistence in human tissues, so therefore it cannot develop and cause inflammation and malignancy. ठीक है? Most 90% of the human exposure is with chrysolite, whereas rest 10% is because of this erionite, crocodilite, and amosite, which are potent to cause mesothelioma. And there is no exact dose threshold curve response. इतना threshold में expose हुआ तो malignancy आएगा ऐसा कुछ नहीं है. There is nothing threshold. Some people might be exposed to very less amount of mineral fibers, whereas some is exposed to large quantities, but there is no threshold that इतना में ये होगा malignancy बोल के. ठीक है, it is influenced by genetic susceptibility, which influences mineral fiber carcinogenesis. Mechanism of asbestos phagogenicity. मैंने जो बोला ना वही है, like cell necrosis, release of HMG1 factor, stimulation of cells and macrophages to release tumor necrosis factor alpha and nuclear factor kappa beta pathway, and finally leading to survival of that injured cell for long time with accumulation of genetic injuries within that cell. Okay. Next, pathology and mesothelioma. Malignancy में three types का है. One is with epithelial component, most common. 70% of the cases are those, whereas 10% are sarcoma type, also called fibrous morphology, most aggressive type. And the other one is the combination of both. Diagnosis by IHC. These mesothelioma have pankeratin positivity, like CK, keratin CK56, calcitonin, Wills tumor 1, which is specific for pleural mesothelioma, and negative for other factors like TTF1 CCA. For epithelial tumors, tumors mesothelioma diagnosis, at least 3 positive, 3 negative should be there for diagnosis. Okay. Coming to clinical presentation, symptoms, 25% of the patients have symptoms for more than 6 months. Most common affected is the right lung because of greater lung volume. Non-pleuritic chest pain, most common at posterior lateral location and lower in the thorax. Other symptoms are dyspnea, it's 60 to 70%. Dyspnea plus effusion in 80% of the patients is seen. Physical examination will decrease sound, dullness, decrease chest wall motion, trapped lung, cachexia, chest wall mass. Laboratory findings, most of the patients will have thrombocytosis with platelets greater than 4 lakhs. In 15% of the patients, it is more than 10 lakhs. And increases homocysteine levels with decrease.
It is in waiting room.
Take a second. Sorry. Okay. Laboratory examination, blood counts तो eosinophilia रहेगी, hypergamma globulinemia रहेगी. And next blood investigation which is important is soluble mesothelin related peptide. इसको याद रखना, soluble mesothelin related peptide. I will tell you later because it is high sensitivity and specificity. Other one is osteopontin, megakaryocyte potential factor. हो क्या पता नहीं. Changes in mesothelin related peptide levels parallel clinical course and tumor size. Lead में और pleural effusion में mesothelin quantity बढ़ गए तो it is directly related to the prognosis of the disease, and it is also a novel agent for targeting in the upcoming days. ठीक है. Plasma ophion, although not specific to mesothelioma, it has been demonstrated to be an independent predictor of survival in mesothelioma and EORCT clinical prognostic index. Tubulin 3, significantly higher levels are seen in mesothelioma compared to others with only asbestos exposure. This is also seen in pleural effusion with mesothelioma patients than with pleural effusion due to other reasons. But mesothelioma is specifically increased होगी. Hyperacetylated HMG1, sensitive and specific biomarker to differentiate mesothelioma patients from exposed to asbestos from unexposed controls. Novel methods ये है SOMAmer proteomic technology, A3 marker ऐसा कुछ दिया हुआ है थोड़ा. Radiologic examination, chest X-ray, pleural effusion रहेगी, pleural thickening रहेगी, nodularity, mass, fixation of the chest wall. And CT में same findings like chest wall thickening, pleural flakes, effusion, fissure, this pleural thickening extending into the fissures and enlarged nodes. Pericardium sometimes irregularly thickened with association of infiltration into pericardial path भी रह सकती है. And CT में when there is indentation which tells that there is infiltration of the tumor into the diaphragm or pericardium. MRI, delayed MRI to see invasion of abutting tissue for both staging and response to therapy. Early contrast-enhanced MRI for patients with minimal pleural thickening to detect disease earlier in high-risk individuals. Diffusion-weighted MRI tells about tumor heterogeneity. Right? PET-CT for nodal and extrathoracic disease. For patients with extrathoracic disease, it always be histologically confirmed. Diagnostic approach होगी thoracentesis, closed pleural biopsy, and diagnostic accuracy is 84% है उसमें. If it is not possible, thoracentesis and pleural effusion tapping and biopsy, thoracoscopy. When large effusion with negative study on thoracentesis, reoccur pleural effusion after initial thoracentesis, and other is open biopsy. Natural history: patients die due to respiratory failure or pneumonia. Prognostic factors from EORCIT and CAL-GB trials they say use biological and clinical factors. Poor indicators are male gender, anemia, thrombocytosis, increased WBC, LDH, poor performance in non-epithelial histology, sarcomatid variety. PET-CT में best survival is seen if that is having low SUV and epithelial histology. Worst prognosis non-epithelial histology and high SUV. SUV होती है greater than 10. अगर SUV है तो we can partly say that patient can have worse survival. Mesothelioma with DAP1 germline mutations, average prognosis 5 years. Staging हम पढ़ लेंगे. Treatment and symptomatic treatment. Unresectable treatment है unresectable tumors. Standard of care is 2 drugs, that is cisplatin plus pemetrexed, which is better in overall survival than single drug. Pleural effusion को thoracentesis करके I muted him. Pleural effusion, thoracentesis, talc fluoridesis कर सकते हैं. 5 grams of talcum powder, asbestos pit talcum powder डाल सकते हैं over 1 lung. And parietal surface success rate is 90%. Mesothelioma trial जो बोलता है thoracoscopic pleurectomy versus talc fluoridesis. Thoracoscopic pleurectomy has better vision control and quality of life at 6 months and 12 months than talc fluoridesis. Chest pain epidural narcotics से पूरा करना पड़ता है. Surgery for pleural mesothelioma can be diagnostic and palliative. Selected cases, maximum cytoreductive procedure or microscopic complete resection can be done, in which persistent disease at the end of the operation is microscopic. Diagnostic होती है for localized disease or with free flowing effusion suspected of having mesothelioma. VATS is allowed for diagnosis. For subtype classification, open biopsy, thoracotomy is more accurate than VATS. Same paper. Macroscopic complete resection. Goal should be R0 or R1, or microscopic complete resection should be goal of cytoreductive surgery, regardless of whether that involves EPP or lung preservative surgery. There are different types of procedure. EPP होता है in extrapleural pneumonectomy, end block resection of parietal visceral pleura with ipsilateral lung. Pericardium and diaphragm should be removed only if they are involved. Extended P/D बोलते हैं like parietal and visceral pleurectomy to remove all the gross disease with resection of pericardium and diaphragm. सिर्फ P/D होता है pleura, parietal visceral pleura removal plus gross disease removal without diaphragm or pericardial resection. Extended में diaphragm और pericardium निकालेंगे, सिर्फ P/D में pericardium और diaphragm नहीं निकालेंगे. Rest all same. Gross disease removal along with parietal and visceral pleura. Partial pleurectomy में जो होता है, we remove parietal and visceral pleura and part of the disease, but not gross complete resection. We leave behind gross tumor. So palliation or microscopic complete resection Who are the eligible candidates? Only 20% of the patients are eligible for this. Start palliation, then followed by assess the patient and see whether he can go for microscopic resection or not. Efficient drainage, improvement in symptoms, partial or full lung expansion, plan accordingly. What are the components that influence the microscopic complete resection? One is patient, surgeon expertise, cardiopulmonary status, patient tumor demography at presentation, rule out metastatic disease, ejection fraction greater than 50%, ECOG less than 1. And whether to perform extrapulmonary pneumonectomy or P by D or extended P by D, they have controversies. So systemic review says that with extrapulmonary pneumonectomy, overall survival ranges from 10 to 28 months with perioperative morbidity and mortality of 80% to and 0 to 12%. In this extrapulmonary pneumonectomy, most common complication is reversible AF, which is seen in 44%. Other issues after this extrapulmonary pneumonectomy are pericardial patch, heart herniation after the surgery due to pericardial patch failure, or diaphragm, since we remove the diaphragm, repair diaphragm also, abdominal contents can herniate into the pleural space, bronchopleural fistula, respiratory failure. Sarcomatid histology and lymph node involvement have an even poorer prognosis and should not be considered for EPP. Okay. Next is trimodality therapy in context of an EPP. Trimodality therapy regi induction chemotherapy like cisplatin with pemetrexed or gemcitabine, followed by EPP, followed by RT. RT can be entire hemithorax or IMRT. Ideal patients are age less than 65 years, pure epithelial histology, no negative, no lymph nodes. Patient should be able to tolerate pneumonectomy. Okay. With TMT, again the median survival is 27 months. In the same extrapulmonary pneumonectomy, overall survival is approximately 28 months. Median survival is 24%. Evolution of lung sparing approaches for microscopic complete resection. 8 studies showed P by D seems to have less mortality, less morbidity, and a comparable OS to extrapulmonary pneumonectomy. The only true propensity matching of EP plus P was reported by Austin et al. With 2:1 ratio. No difference was seen in major morbidity. 90% mortality favored P by D procedure is best. Freedom from recurrence was similar in both the groups. OS significantly longer for P by D groups. Another such trial is Mars 2 trial, extended PD versus EPP. Coming to chemotherapy, first line chemotherapy was first stated by Vander et al. Cisplatin with gemcitabine phase 2 trial. Later, it has good response and overall survival rate. Later was tried with MVP drugs and vinorelbine, but they have lesser benefit compared with gemcis. So then comes the standard of care with antifolate regimen, pemetrexed. Mechanism of action is purine pyrimidine synthesis inhibition by inhibiting the following enzymes. Malignant mesothelioma cells overexpress the alpha folate receptor, and high levels of expression of this receptor may make MM more susceptible to antifolate drugs. Okay. Another study is by Vogelzang et al. 460 patients with mesothelioma, 1:1 ratio almost. They were given with cisplatin with pemetrexed versus cisplatin and the placebo NS. And they have noticed that median survival and response rate was good with cisplatin with pemetrexed. And pemetrexed has its own toxicity, which can be reduced with B12 supplementation and folic acid. Second line chemotherapy होती है, rarely successful है second line chemotherapy, but patients can be tried with second line chemotherapy if they have not received the pemetrexed in the initial first cycle, or if they have good DFS, they can be given with they can be tried with pemetrexed once again. ये novel therapeutic approaches तीन है, angiogenesis inhibition, immunotherapy, mesothelin directed therapy तीन दिया है डेटा में. Angiogenesis was with VEGF inhibitor. This mesothelioma cells exhibit a higher quantity of VGF receptors and proteins. High serum levels correlate with prognosis, and high pleural effusion levels also correlate with prognosis. There is a study by a French intergroup which shows that MAP study, उसमें mix किया हुआ है mesothelioma, Avastin, pemetrexed, cisplatin study है, 446 patients है, RCT phase 3 trial है, and they have seen that OS has little bit improved with cisplatin, pemetrexed and bevacizumab. Guideline now say that patient should be given with cisplatin, pemetrexed, bevacizumab as a first-line therapeutic option. Other multi-kinase inhibitors were tried, but all those have failed. Next comes the immunotherapy. IHC shows PD-1 expression in 20 to 40% of the cases. But sarcomatoid histology shows higher percentage of PD-L1 expression than epithelioid variety. CTLA4 inhibitors, tremelimumab, it has shown some benefit, but the final conclusion is that CTLA4 inhibitor has not much use in treating the patients with malignant mesothelioma. Whereas PD-L1 inhibitor with keynote trial 028 pembrolizumab and French cooperative thoracic intergroup nivolumab, they have shown that second line or third line therapy, there is some benefit with increased overall survival. The primary endpoint is disease control rate at 12 weeks, which was 40 to 50%. 40% was 52%, and median overall survival with nivolumab is 14 months, and nivolumab with ipilimumab, they have not reached it. Based on keynote 28 and IFCT trial, NCC guidelines were updated to include nivolumab alone or nivolumab plus ipilimumab and pembrolizumab as second line treatment options for NPM. So chemotherapy में first line होगी standard of care cisplatin, pemetrexed, bevacizumab. Second line में होगी nivolumab with ipilimumab. Mesothelin directed therapy. Mesothelin is a immunogenic cell surface glycoprotein. इसका function है cell proliferation, signaling, adhesion and metastasis. Normal tissues में होगी pleura, peritoneum and pericardium. But in malignant mesothelioma, it is expressed by all tumors, all cells. Example है amatoximab, chimeric immunoglobulin IgG1 antibody. This along with standard of care chemotherapy, वही cisplatin, pemetrexed दिया है तो overall survival बढ़ती है. But progression-free survival difference is not there. Another such one is CRS-207. This is recombinant live attenuated Listeria monocytogen bacteria, engineered to express mesothelin. Phase 2 study है 38 patients है. When given a standard of care, high response rate is seen in 60% of the patients. Disease control rate in 94% of patients. Median PFS 8.5 months. Another such is mesothelin immunoconjugate consisting of anti-mesothelin fused to pseudomonas exotoxin. Another one is anti-mesothelin antibody conjugate linked to maytansinoid tubulin inhibitor DM4. वही है भाई. Last one is CAR T cell. That is in the early stages of trials, and radiotherapy का role कम है, but rarely used as a curative treatment for MPM due to inability to treat a large volume of disease in chest with curative radiation doses of greater than 60 because of risk of severe damage to normal tissue. Combined surgical resection and adjuvant RT. Rush et al. From MSKCC phase 2 trial. Extrapleural immunotherapy followed by RT. 54 gray in 30 fractions. Anti and post repeats. Median survival of 17 months is noted. 13% local regional control, but majority have them distant meds. So, if the patient can tolerate the entire procedure, EPP followed by RT is the better option. Better could be IMRT. 2 trials from MD Anderson by Rice et al. And Foster. They have showed EPP IMRT of 63 patients. Median survival of 14 months. 3-year survival of 20%. Distant meds of 54%. And significant toxicity is pneumonitis, which is seen at the end of 30 days. Another one is helical tomotherapy. बस इतना ही लिखा है भाई मैंने. उसमें भी उतना ही है डेविटा में.
या भाई थैंक यू.
बहुत ज्यादा था वैसे.
Thank you.
ज्यादा था पता है, मैं पता था, पर इसमें तो पूरा भी याद नहीं रहेगा. जो याद है वही लिखेंगे.
हाँ, पर डेविटा तुमने अच्छे से पढ़
जा।
लिया है। इतना अच्छा मैंने अभी डेविटा पढ़ना शुरू नहीं किया है।
मैं तो ये 1 हफ्ते से बना रहा था इसको।
हाँ, इतना बनाने में तो टाइम लगेगा ही।
आदमी है वो। इसमें तो यही था।